Hi everyone and welcome to the Emergency Physicians ECG course. This is Hesham Ibrahim. I'm one of the emergency medicine consultants in the United Kingdom, and today we're going to continue with case number 7 that we've started a few days ago in the previous video, and that will be the second and the last part in this case. So the case that we talked about was about a 7-year-old female patient presented to ED with intermittent palpitations and pre-syncopal events. So her observations were all normal. Her clinical examination was absolutely fine. So she's had an ECG, and this was her ECG. So what I want you to do now is I want you to click the pause button, have a proper look at this ECG, try to interpret it yourself using the approach we've talked about in the previous video, and then we're going to discuss it together. Okay, I hope you've done what we've agreed to do, and yeah, let's move on. Let's go through the suggested approach that we've talked about before when it comes to interpreting pediatric ECGs. So exactly the same as the adult one. You should start looking at the QRS complex and assess the rate, the rhythm, the width, and the axis. Then you move on to the P waves and its relation to the QRS. Then you check the intervals. So that's the PR interval and the QT interval. Next is to check for chamber enlargement, including both atria and ventricles. And then you check for ischemia. That's going through the ST segment, T waves, and the Q waves. And lastly, anything else. So this is the approach that you should use dealing with adult ECGs and pediatric ECGs. So let's analyze our ECG and see what we can get out of it. If we start by asking our first 4 questions about the QRS, looking at the rate here, I would say it's within normal. Roughly, it's going to be 60 to 70 beats per minute. In terms of the rhythm, it looks regular to me. And looking at the width, it's got a narrow complex. So that is so far. Looking at that, we've got normal rate and regular rhythm and narrow complex. And if we look at the P waves, we will notice that they are upright in the limb leads. So 1, 2, 3, AVL and AVF, and they are inverted in AVR. So that's a normal sinus rhythm. And the axis here, looking at lead 1, we will notice that it's pointing up. Looking at AVR, AVF, it's pointing up. So that will make it a normal axis. So far, everything is normal. And then we're going to continue with our other questions. So looking at the P waves, I can see only one P wave before each complex, and the PR interval looks okay to me. We're going to skip the QT interval at the moment, and then we're going to check for chamber enlargement. And again, I cannot really see any signs of atrial enlargement or ventricular enlargement here. And then from the ischemia point of view, there is no ST elevation or depression. There are no Q waves that I can notice. We've got T wave inversions in V1, V2, and V3, but we now know that this is normal in children. So I'm not going to count this as a sign of ischemia. So the only thing that we haven't mentioned about yet in this ECG is the QT interval. And to be honest, if you look at the QT interval here, just with your naked eyes, it looks really prolonged. So I think the concern in this ECG should be the long QT interval. So let's quickly, for our beginners, cover these parts from the ECG. So let's start from the beginning. We have got here the P waves, followed by the QRS, and then the T wave and the U wave. And what I want you to notice is, I want you to, let's just highlight some stuff. So I want you to notice that. So this is our P wave. The beginning of the P is here. So from here to there, this is called the PR interval. But from here to there, so this is called the PR segment. So the difference between an interval and a segment is that any interval should have a wave, at least one wave within it. So from here to there is the PR interval because it's got the P wave within, but from here to there, that's the PR segment. Then we have the QRS complex, then from here to there is the ST segment, but from here to there is the ST interval because it's got the T wave within. And from here to there is the QT interval. So the QT interval includes within the QRS, the ST segment, and the T wave. So this is just to give you an idea about some quick basic stuff to ensure that they are there. Cool, let's move on. So what's normal in terms of the QT interval? Well, to be honest, the numbers vary. It depends upon the age because they change with the age, and they change depending upon whether you're a male or a female. And to my simple ED brain, the numbers that keep changing are really tricky to remember, and I can't really keep them in my head. So I'm left with one of two options: either to double check every time I see an ECG what's normal for this particular patient and go online and try to find it or write it down somewhere, or to stick to less accurate numbers but easier to remember, and I've chosen to stick to the easier option. So normal QT interval in my head is this. So 333 to 444. Anything less than 333, that's short. Anything above 444, that's long. This is how I remember it. Be careful, these numbers are not accurate, but they're not far from being accurate and you will never forget them. Scary numbers are the 500. So any QT interval that is above 500, be worried, keep an eye. Good. So how do we estimate the QT interval? So there are many different ways. If you're going to stick to the accuracy, there are so many different formulae. So this is one of them. One of them, that's the Bazet formula. So you can use this to calculate your QTC, the corrected QT interval. And there are so many others. Or you can use your just naked eyes. So if you look at the RR interval, so the T wave should end before the halfway between the two R intervals. So from here to there, so that's your RR interval. The T wave should end before halfway. If the T wave finished after this line, then this is likely to be a prolonged QT. So this is the rough way of just looking at an ECG and thinking, yeah, the QT here, it looks prolonged or not. So let's talk about long QT syndrome. There are so many causes to have a long QT interval. Let's quickly go through them. There are, I like to put them under four main categories. The first category is the congenital one. Few syndromes to think about. The famous one is Romanov-Ward syndrome. Then we're going to talk about the metabolic, and long QT is caused by hypo. So you've got 5 hypos to think about when you're faced with a long QT syndrome: hypokalemia, hypocalcemia, hypomagnesemia, hypothermia, and hypothyroidism. Those are your 5 hypos that will cause, the 5 metabolic hypos that will cause long QT syndrome. Then you've got the drugs, and the list is really long. Think about sodium channel blockers, think about antipsychotics, antihistamine, ondansetron, antidepressants, antibiotics, so azithromycin and clarithromycin, and methadone. So yeah, the list is really long when it comes to this part. And then lastly, some other causes. The important ones are raised intracranial pressure and acute coronary syndrome. So these are the causes of long QT interval. So here is a good example to show you the danger of having a long QT. This is an ECG for a lady that I've seen a few years ago. And I know that the ECG looks really bizarre, but if we focus on some areas, you can easily recognize that the QT interval here is fairly prolonged. So I think the end of the T wave here is probably there, and that's definitely more than halfway of the RR interval. So the QT here, it looks prolonged, and actually the calculated QTC for this lady was, I think, heading towards the 600. So few minutes after having this ECG, this is what we found. So she's had this. So we were repeating the ECG, and the repeat ECG, the repeat 12-lead ECG, she collapsed while having it printed, and she's had this nice, lovely looking torsade de poids. So polymorphic VT, and by the way, she did really well. But yeah, and I'm really proud to have this ECG in my collection, because you don't really see a 12-lead ECG for a cardiac arrest every day. So let's go back to our case and see what happened. So this was the ECG of this 7-year-old girl, and she was known to have congenital long QT syndrome. We've seen this lady and we've observed her for a while and discussed her with the pediatric cardiologist. That was in Poole Hospital, United Kingdom. And actually she did really well. She didn't require anything apart from just some observations. Her bloods were all okay. So she was sent home later in the day to follow up with a pediatric cardiologist as an outpatient. But if you look carefully in this ECG, there is another thing that should catch your eye. It is this part here. So the machine thinks that the QTC is 378. And this is really bizarre, because looking at the ECG, the QT looks really prolonged. So 378, I would say this is within normal, if not heading towards the short side. So how come that our eyes are saying something and the machine is saying the exact opposite? I think the answer here is there. So the machine said that the heart rate is 126. Would you agree with this? I would definitely disagree. Looking at the heart rate here, as I said, I think it's kind of between 60 to 70. So why did the machine calculated the heart rate as 126? I think the answer is depending upon which lead did the machine used to calculate the heart rate. If we assume that the machine used lead 1 to calculate the heart rate, the machine will look at this and count it as a complex. Then it will look at the T wave and it will find that actually it's got a very similar shape and height to the complex. So it will count this as a complex. So what the machine is going to do is it will double the heart rate. So if our heart rate here, if we think it's kind of 60, then the machine will count it as 120. And remember that the heart rate is included in any calculation to the QTC. So if you've got the heart rate wrong, your calculation will be wrong. And I think this is the reason behind getting this very wrong QT interval. And this is it about this case. So in a quick summary, this was a really good case that we've used to cover 3 main topics. We've talked about the pediatric ECG, we've talked about the QT interval, and we've just slightly covered the accuracy of the ECG machine in interpretation. Remember that the approach to any pediatric ECG should be the same as any adult one. Remember that you should be careful about the differences in normal values between adults and kids when interpreting an ECG. And be careful, when it comes to an ECG machine interpretation that doesn't make any sense to you, trust your own eyes. Lastly, we've talked about the causes of long QT interval. So we talked about the congenital causes, the metabolic causes, the drugs, and some others. And I guess this is enough for this case. And yeah, I hope you found this useful, and stay safe. I'll talk to you very soon. Bye for now.